and gentlemen, thank you very much for the invitation to speak here to you. And I think we have a tight schedule this afternoon, so I'll really start with my speech. And I want to talk about CDH or D.D.H, developmental dysplasia of the hip, and I want to talk to you about a special cup replacement that we are doing in our city. And that's why if we use this classification of arthroplasty, you know that you have a shallow acetabulum or you have a high-riding femur which has a new contact at a new acetabulum area, or you have a real dislocation of the hip. But you all know that. But what I want to stress is if you think about CDH and especially about hip arthroplasty in CDH, never forget that you also have a significant amount of anteversion of the femoral neck. And this is from a book from Putti, from Italy, where I took it, which is increasing with age. And so if you think about the femur, never forget that you have a short femoral neck, which you have to deal with. So you have a different offset than you had before. You have a markedly anteverted femoral neck. And not only this, but you also have a posterior displacement of the greater trochanter. And that goes with some significant changes in soft tissue alignment there. And you have a narrow and straight tapered femoral canal, which also gives us some trouble. But coming back to the acetabulum, which I want to talk about to you, we have this arthroplasty classification in 3 different grades, which is the shallow acetabulum is grade 1, the femoral head articulating with a new acetabulum is grade 2, and the high dislocation is grade 3. Here are some pictures, some radiographs from grade 1 with a shallow acetabulum and a high angle here with the new articulation of the femoral head with a new acetabulum and with the high dislocation of the femur. Another one that many of you might know, which is more used in the English-speaking countries, is the one of Crow, which describes the degree of dislocation according to the coverage of the femoral head, which is divided into quarters, and it's sort of compares to the one of arthroplasty. And if we have to deal with patients with CDH, often we have to think about the procedures that those people have had before. So they all had some different kinds of pelvic osteotomies, they had femoral osteotomies, so we have to deal with a lot of problems that we have to think about in advance. And don't forget the soft tissues, because the soft tissues, especially in the high-riding dysplasia, come with shortened muscles, especially the abductor muscles are a problem, with shortened sciatic and femoral nerve, because it's a developmental disease, and shortened vessels also. Now, this is a clinical picture of the CDH on both sides, and now you have to think about the options that we have. The options are to put the acetabulum, to put the cup at the regular area, or to put it at the area where it was due to the CDH problem. You can try to medialize the cup doing a cotyloplasty, which is just a fracture of the inner wall of the ilium, and which is good for the biomechanics because you decrease the lever arm of the muscles. But if you don't do that, if you don't want to do that, if you want to keep bone in there, then you have to think about an acetabular augmentation, which can be done by aerograft, you know that, or which can be cemented. at the same, in the same area, or you have to think about cementing the cup anyway, or do a cementless fixation, or you can do a reinforcement rings like these that we use in Germany. It's the Müller ring or the Ganz ring that we take. And in this case, we used a reinforcement ring which functioned well. And this is an example for an acetabular augmentation with screws. Maybe it wasn't really necessary in this case. And I want to talk to you about a system that we use. It's the cranial cup system. It's an oblonged cup, an oval-shaped cup with a macroporous structure. And it has an oval elongation here, as you can see, which centers the head of the hip because of this oval shape, and it goes with a three-dimensional macroporous structure. You saw that on the last slide. Has a cementless fixation, and it comes with or without a flap if you want to have a stronger relation to the bone, and you can also use a central peg for more stabilization. I want to talk about two procedures that we compared, the acetabuloplasty and the cranial cup system, for the same indications. And in some patients we prefer this acetabular, this cranial cup system, just because it's a primary stable system, a cementless fixation. It can be weight-beared immediately, and we can restore the center of rotation with this system, and we have a very stable primary situation. We don't believe in allografts at all. Now, comparing these two groups here, it's the cranial cup and the acetabuloplasty. We did between 1999 and 2006. We did a comparable number of patients with these procedures, and you see that a lot of prior procedures have been undertaken in these patients too. Most of them were from grade 1 or grade 2 from Hartophylakides, as you can see, and we didn't treat any high-riding dislocations with this procedure. Patients were evaluated clinically with range of motion and so on. They gave their visual analog scale, pain measurement, Harris hip score, and we compared Harris hip score to the Hartophylakides grading for dislocation, and we did an SF36 measurement and the subjective evaluation. Radiological signs for loosening were analyzed, and migration was analyzed, lysis was analyzed, and resorption of the bone block, as well as the center of rotation, as you can see. And in this 6-year evaluation period, we had a survival of 100% of the patients in both groups. We had a restoration of the center of rotation in 30 cases in the first group, in the cranial cup group, versus 35% patients in the plastic group, which was equal in both groups, basically. Complications were not so many in these groups, and we had 2 radiological signs for loosening without clinical symptoms in the cranial cup system, and we had signs of resorption of the bone blocks in 30% of the patients in the acetabuloplasty group without any problems, without any symptoms. So here's an example 4 years post-operatively after the cranial cup system. And here another one of a 55-year-old lady 5 years after the operation. On the right side here you can see this oval-shaped cup system. And this compares to the other group 2 years after the implantation of a regular cup system with an acetabuloplasty in a 42-year-old patient. Now, the results were pretty much the same in both groups. So we had a highly significant reduction of pain in both procedures, And we had a highly significant improvement of function in both procedures, as you can see, comparing the HS score between the two groups. We had no significant, interestingly, we had no significant correlation between the HSS score, HHS score, and the degree of dislocation of the hip. And in the subjective evaluation, all the patients wanted to have the procedure again. They would accept the procedure again. So comparing the results in the literature with our results that we had in both groups, we have similar rates of HHS scores. And in conclusion, there's no statistical difference between the clinical outcome of both groups, so we can use both procedures safely. And we concluded that for us, the age of the patient is the most interesting part in the indication of this cranial cup system, because in elderly patients, we prefer the cementless cup system to get a primary stable situation and a good fixation of the implant. Long-term results are needed in both groups, and to give you some information from the literature also, it is known that it is important that superlateral positioning of the acetabular component leads to a very high hip forces, so we have to avoid that in any case. Higher loosening rates are known if the hip center is placed more than 50 millimeters superior to the regular hip center. Cement to fill acetabular defect has not been associated with a satisfactory long-term outcome, and 70% of the cup should be covered by host bone. So that's also important, because you could do some of the cases also without either a bone block or without an oval-shaped cup, certainly. So thank you for your interest, and this is a famous building, the residence in WÜRZBURG, and I invite you to come there. It's a very nice place to be. Thank you.